Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
On today's episode, we are discussing bile acid malabsorption. This is a topic that I definitely see in my practice, but need to learn more about. So let's just dive in. Alana, what is bile acid malabsorption? How common is it?
Bile acid malabsorption is a condition when your small intestine is not doing what it's supposed to do. Physiologically, what should naturally happen is in the beginning of the digestive process, your gallbladder and your bile should respond to fat within the diet and dump bile acids into the small bowel, and those bile acids should bind with fat. And then when they get to the bottom of the small intestine, those bile acids should be resorbed. About 95% of them should be reabsorbed, and therefore bile should never go into the large intestine. What happens with bile acid malabsorption is something goes wrong along the line, and those bile acids are not reabsorbed. And when they're not reabsorbed, they enter the large intestine, and two things happen at the same exact time. The first is that the bile acids pull in a lot of water to follow them into the large intestine. The second is that peristalsis, or the movement of the large intestine, really picks up speed, and that causes basically a diarrhea dump that's mainly fat and steatorrhea. So the keynote for a bile acid malabsorption is to have steatorrhea or fatty stools. And the most important thing to know about a fatty stool is that is a sticky stool that's difficult to clean up, off the toilet, and that comes on pretty rapidly.
And is it always diarrhea?
It's generally always diarrhea. It's a bile acid malabsorption syndrome.
Okay, and what would this be caused by?
So it can be caused by four separate things. The first thing that can cause it is some kind of other disease. So celiac disease, which is a malabsorption disorder, inflammatory bowel disease, Crohn's disease. The other things that can cause it is IBS and SIBO disorders. It can also be caused by too much acid getting dumped within the intestine. And the last thing that can cause it is some other kind of malabsorption disease, like something's wrong with the pancreas, something's wrong with the gallbladder, something like that can also cause it. There's also unclear causes, and IBS and SIBO generally fall under that one.
That's interesting. I'm a little curious about the crossover with that and another topic that we have discussed on our own and we'll probably cover on another topic, exocrine pancreatic insufficiency. How do those two relate?
Sometimes you can have them together. However, exocrine pancreas insufficiency is another one of those diseases where you have a malabsorption of fat. Because what the pancreas secretes is three enzymes: lipase, which breaks down fat, amylase, which breaks down carbs, and proteases, which breaks down protein. And so steatorrhea can be partially caused by bile acid malabsorption. It can also be caused by exocrine pancreas insufficiency. You can have both at the same time, or you can have one at a time. And both of those can have the underlying cause of IBS or SIBO as the causative issue.
Okay, but so what if someone has IBS-C? Could they still have exocrine pancreatic insufficiency or bile acid malabsorption?
So it won't. Bile acid malabsorption and exocrine pancreas insufficiency fall under diarrhea disorders.
Okay.
However, they can absolutely have a pancreas, especially a pancreas. But bile acid malabsorption, you're never going to see constipation, ever. Mainly because you need the large intestine to get filled with water and to speed up peristalsis. So you're never going to see constipation. But you can see formed normal stools with pancreatic insufficiency.
Okay, that's helpful.
What about folks who have constipation and we see steatocrit on a stool test?
Steatocrit is a really, really interesting test. Should we talk about how you diagnose it?
That'd be great.
Okay. So when we're talking about diagnosing bile acid malabsorption, I'm gonna be completely honest. Like exocrine pancreas insufficiency has tests that are really, really reliable and very, very accurate, assuming you have a formed stool.
And you mean the fecal elastase?
The fecal elastase one, which we'll talk about when we dive into EPI. Bile acid malabsorption really does not have that awesome of a panel to test it. So the first thing that you can look at is you can look at a quantitative or qualitative fecal fat. Fecal fat is a very, very gross test, and it really breaks my heart for all of those lab techs out there who have to run these tests. So when we're talking about fecal fat, we're talking about either qualitative or quantitative, right? Quantitative fecal fat is when you have the patient do this really insane diet with 100 grams of protein, 180 grams of carbs, and 100 grams of fat, and they do this disgusting diet for 6 days. 3 days before they start their collection, and then they take their poop and they collect it every single bowel movement that they have for the last 3 days, knowing that these people are diarrhea people. So they have to collect buckets of poop, right? But that's not where it ends. Then they bring, it's really gross. Then they
Where do they put the collection?
They store it in their fridge.
Of course.
Yeah.
I don't have any patients that would want to do that.
This is the problem with quantitative fecal fat. So then they store it in their fridge, and then they bring it to this lab tech. And whoever my protagonist lab tech is, they end up having to wade through this stool, this abundant diarrhea, steatorrhea, thick, oozy stool.
We get the picture,
okay.
Anna.
And they have to wade through that stool and figure out what percentage of it is fat. That is a very, very accurate marker for steatorrhea, exceptionally accurate. The problem with that marker is, at least in my private practice, getting a patient to comply with this type of diet for 6 days with these chronic diarrhea patients. It's almost impossible.
Or even collecting their stool for that long, which is why we probably want to use the qualitative.
So that there's problems with the qualitative. The qualitative fecal fat is literally just a random sample, right? So we take a random sample, they collect it, they drop it off at the stool, and they're looking at basically the amount of fat globules within the stool.
And this is usually the test that's on stool panels if they are
It's going to either be a quantitative or a qualitative.
Got it.
Like a random fecal fat is always going to be a qualitative. You're looking at the quality of the stool. That's how I remember it.
Right. And most of the functional stool testing we do is a one-time collection. So that's probably what they're looking at.
So there's problems. So qualitative, the biggest problem with qualitative is it's ridiculously objective, right? So it's ridiculously subjective. We're not looking at, there's no computer imaging. A lab tech looks under the microscope and says 1 plus normal, 2 plus a slight increase, 3 plus a moderate to abundant amount of increase.
So it's like urinalysis, essentially.
But even less objective than a urinalysis. Like a urinalysis, at least there's some ranges where you can see, and there's some positive and some negative.
Right.
So 1, it's very, very subjective. 2, when they do comparisons, and there's this one study that I was looking at, I will put it in the show notes. There's this one study that I was looking at that compared the fecal fat that when they gave the diet to a random. And if they had severe bile acid malabsorption, it was pretty comparable. Like they found it almost every time. However, if they had mild to moderate bile acid malabsorption, it was missed somewhere between 50 to 75% of the time. So the fecal fat, the random fecal fats that we're running on our functional stool tests really are missing a lot of them. So that's not a great marker.
So question about that. So if it is elevated on a random qualitative sample, is that generally predictive of someone who has a more severe form, or could it just be an intermittent issue for some people where they don't actually have severe and it's just showing up on that particular sample that you analyzed?
The answer is it's probably more predictive.
Okay.
Because it was pretty equal to quantitative. I get those flipped in my head. The way I remember them is the qualitative, the fecal fat is looking at the quality of the stool. And so that's when it's a subjective finding. That's how I remember it in my head.
Right.
So there is this other test, and it's a test that, so there's this other test that had actually a lot of validation in the early 90s, and that's called a steatocrit test. So that's a test where they take a random sample, but they go through an acid steatification process, and I don't know what that process is, but so they acidify the stool, and that's always a random sample without diet, but that actually has been pretty well verified to be an effective way of measuring um, bile acid malabsorption, right? So that's an effective way of measuring bile acid malabsorption. But it's only used in the functional tests, and it's not used throughout, even though when I did my data search, I think that there was something like, I think that totally there was like 54 studies on steatocrit, and 45 of them were done in humans. So in the 90s, they were doing all this validation, and they found that steatocrit is a good marker for the bile acid malabsorption. But then they, in the 2000s, they started looking at it and seeing if it was a good replacement for exocrine pancreas insufficiency screening and fecal elastase 1. And so the steatocrit is appropriate as a good diagnostic marker with a random stool. Like, I think it was 92% equal to the diet stool collection, but it wasn't, it's not used. And so very, very few of the functional tests are using it.
So just to clarify, they're doing more of the random qualitative fecal fat, and they're not reporting the steatocrit, but there are some that do both. And in that case, the steatocrit would be a more useful marker than a random qualitative fecal fat.
It would be more specific for sure.
Okay.
Yeah. There's also another test. Well, there's two other tests. One that's not available in the US, but we should talk about it because we have listeners all over the world. That is an imaging study. That's called SEHCAT, SEHCAT. And this is a little bit of a crazy study, but by far the most accurate. So what you do is you go into your imaging center, and they feed you a meal with a certain amount of bile acids in the meal, right? And then at 30 minutes after you eat the meal, they take a picture of your using imaging. So they take a film, and then after that, you go home, and then 3 days later, you come back and they retake the image. And what they're looking at is they're looking at how many of those radio-labeled bile acids that you ate 3 days ago are circulating. Because if everything was working the way it should be 95% resorbed. Right?
Right.
And so that's by far the best way to measure. The problem is lots of things can cause diarrhea. This falls under diarrhea disorders. And the problem with that is, let's say you're wrong. Now they're sitting with a highly resorbed nucleotide labeled bile acid that should be reabsorbed at 95%. So you're just sitting with radio labeled bile acids for ...
Yeah, I can see the problem with that.
So that's what they do in the rest of the world. That's not what they do in the States. In the States, we have this other test called 7C4 test. It's offered by one lab, Prometheus Lab, which is not a functional lab at all. The problem with that test is it's only looking for 2 out of the 4 causes of bile acid malabsorption. So it's just very expensive and not nearly as sensitive.
Okay. So I have a question about, could you do an empiric trial of a medication that sequesters bile acids to see if they respond, and would that be specific, or does something like cholestyramine just work regardless of the diarrhea cause?
So that is exactly what I do.
Okay.
That is exactly what I do. The drug that I use is cholestyramine. It is very cheap. It is by no means good tasting. It tastes like chalky orange.
Right.
But let me tell you guys about a patient story. So I just saw a patient yesterday, and she has one of the things that happen with bile acid diarrhea, which is awful, is patients will often like wake up in the middle of the night stooling, like in their bed. They'll have accidents. It's never normal to have bowel movements in the middle of the night. That's just not normal. And so they'll wake up. There's a lot of urgency. You don't get a lot of notice if you have bile acid malabsorption. There can be a lot of bowel accidents in the more severe stages. I mean, it's not awesome.
Right.
And she had really urgent, out of nowhere, she'd be in the grocery store. She'd feel it slipping because it's so oily and greasy. The rectum can't control it. I mean, it's really kind of terrible when you have it severely.
Yeah.
And so I was taking the history, and I was like, I got this. I know exactly what this is. Like, I ran a stool test on her. The steatocrit was high, but it was borderline high. And I was like, let's not do all the crazy things. Let me give you, 2 weeks of cholestyramine. Let's just see. And I saw her on Friday, and she was like, dude, I thought my bowel movements were bad before. Now they're awful. Different awful. Yes. She was like, I can no longer poop. Like, I'm not having diarrhea. I'm not having diarrhea, but I can no longer poop without taking a shower because it's so like muddy.
Oh,
It just like it did not correct her at all. Well,
okay.
it corrected the diarrhea some, but it gave her a different set of problems.
How many packets was she on?
I started her on 1 packet a day. No, I think I probably started her on half packet once a day, and she went up to 2 packets a day.
Wow.
But it was the bowel movements. It was just like so much, and she was wiping like so. Then I irritated her hemorrhoids because she was wiping like 100
Yeah.
times.
So she needs a bidet too, which
So-
I recommend to a lot of my patients. But go ahead.
So that's exactly what I did. I did an empiric trial. Does cholestyramine work? If it works, great. It's way cheap. We know we're on the
Yeah.
right track. There are other drugs. One is a chewable, one is a tablet. Like you don't have to do the chalky powder, but I usually start with the chalky powder.
So
'cause
back
it's
to your
cheap.
patient. So she did not have bile acid diarrhea. You had
No.
to go back to the drawing board.
And she had a positive steatocrit is a steatocrit over 15.
Mhm.
She had a steatocrit of 6.
Okay.
But with her clinical picture of having urgent diarrhea that came out of nowhere, that was greasy, it was steatorrhea,
Right.
I was like, let's not deal with biofilms, which we'll talk about later. Let's not deal with biofilms. Let's just deal with this fecal fat because it's such an easy monitor.
Mhm.
So this should be one of the things that we're easily, very quickly listening to that symptom picture of steatorrhea
Mhm.
and then treating.
Right.
So greasy stools, diarrhea, you can just consider
Cramping, watery pain, distension.
consider a trial of cholestyramine.
Yeah.
My question about cholestyramine has been I know it was originally developed as a bile acid sequestrant for cholesterol management.
Yeah.
And it's contraindicated in elevated triglycerides because it can actually make your triglycerides go up. Do you have any options for folks who already have high triglycerides?
So there are natural agents. I will say, in my experience, the natural agents don't work as well. But
That's what I've seen too.
But there are natural agents. So if we're talking about natural agents, the data is spotty at best. But we're talking lecithin is a natural agent.
Sunflower lecithin.
Sunflower lecithin, yep. And that is a natural agent because it actually works in the creation of bile salts or bile acids. That like it's one of those rate limiting nutrients that you need to make more bile acids.
And I believe that actually helps triglycerides.
And what kind of dosing are you using for that?
I think that 2 grams 3 to 4 times a day
Okay.
with meals. But with all of these things, it's such a bell curve
Yeah.
where there is a lot of trial and error.
And it has to be sunflower lecithin?
Just because soy is just dirty.
More allergic and
Yeah.
GMO and such.
Yeah.
Okay.
Yeah. So that's an option.
Mhm.
Choline, which is one of the, choline is what makes up lecithin.
Right.
The choline can sometimes work for these patients. Bitters and improving the rest of their digestive process can
Right.
sometimes work. Let's say, there's 4 underlying causes, including the idiopathic one, ... IBS and SIBO. Cleaning up their IBS and SIBO can sometimes work. I'm on a biofilm crusade. Cleaning up their biofilms can sometimes work, but sometimes they just need to stay on cholestyramine. I have a much better track record getting patients off of enzymes for EPI than I do getting them off of cholestyramine for bile acid malabsorption.
And is cholecystectomy one? I had a patient who had to just be on cholestyramine indefinitely for this after cholecystectomy. Is that a frequent cause, or what have you seen?
I think that 10 to 15% of people, I think the data says 10 to 15% of people who get cholecystectomy will have a bile dumping syndrome.
Okay.
And that is actually different. It has more to do with the fact that the liver isn't concentrating the bile as effectively as the gallbladder.
Mhm.
And so there's more bile being dumped.
As opposed to just the bile not being reabsorbed with other causes?
With small bowel causes.
Okay. And have you seen any potential links with infectious causes like protozoal infections or anything else that you've seen in your research?
Yeah, no, not in my research. I don't think I don't think I read any papers on protozoa or parasites being the underlying cause. I haven't obviously read all the papers.
Right.
But in my experience, the microbiome, both in the large and small bowel, is a community.
Mhm.
And when you have outliers who's like Giardia, what it does is it changes the makeup of the microbiome.
Right.
That is how it becomes a pathogen. That is by no means the only pathogen that does that.
Right.
But yes, so I feel like it's part of the cause. There's no good numbers to tell you how significant.
And do we know if there's an autoimmune cause at all, or?
Crohn's disease, celiac disease, both are autoimmune causes.
Mhm.
Crohn's mainly because of the fact that the terminal ileum is involved in 85% of patients, plus short bowel syndrome is one of the places we will see this very frequently because we're resecting often the ileum where those bile acids get absorbed.
Makes sense.
How often do you see this occur with exocrine pancreatic insufficiency, or is it too hard to tell?
So I feel like if I'm seeing a steatorrhea and they have EPI based on their fecal elastase 1
Yep.
from a formed sample, because that's the rate limiting step for fecal elastase 1, I'm saying I'm going to assume it's the EPI and not the gallbladder, mainly because I think EPI causes significantly more malabsorption because
Right.
the lipase and the proteases are also involved. I'm sorry, because the amylases and the proteases are also involved, not just the lipases.
Right. So I guess maybe in wrapping up, final questions here for this today. What types of symptoms are you looking at that you would have this as like high level of suspicion?
That's a great question. So urgent, greasy steatorrhea, greasy, difficult to wipe up. I can talk about what the poop looks like forever, mainly because it just keeps people interested. But greasy steatorrhea, bile accidents, stooling in the middle of the night, that's not normal.
Right.
Urgent stools that follow really fatty meals. You're like just the obvious fat malabsorption presentations.
And I have one follow-up question before we kind of wrap things up. Does giving lipase help at all, or have you done that as part of your protocols?
So lipase will be effective if their steatorrhea is caused by EPI.
Okay.
But if their steatorrhea is caused by malabsorption of the bile acids in the small bowel, lipase won't do anything except probably make the stool even more. Oh, that's another thing. These patients often have very burny rectums. Like their rectum will hurt and burn because bile acids should never be in the large intestine.
It throws off the pH.
It throws off it just goes through you so fast.
Right.
And it's like you have no control and it's like vicious.
Right.
It's
so
really not nice.
If they have both conditions together, then you may consider digestive enzymes, which we'll talk about in the other episode.
Yeah.
And I also wasn't joking about the bidet. Since my husband is from Japan, I really don't know what we're doing in America with toilet paper, but I highly recommend a bidet. Ours is on the way.
Is it really?
It is. It's getting installed this week.
I feel like
I've been waiting for it for 3 years.
I got to tell you guys, I must be too American because the thought of having to rinse off after I'm done with my business.
Why would you ever wipe your dirty hands with dry paper? Why would we do that to
a recipe for hemorrhoids?
It's just not a good idea.
Hemorrhoids we need to talk about hemorrhoids.
The bidet, I recommend the one with the washing off and the dryer, and there's a remote control.
Is it going to be a Japanese
Toto
one?
brand?
Yeah, of course it's Japanese. The Japanese have bowel movements figured out.
Well, in conclusion here, we like to wrap up our episodes with one final takeaway, whether it's a lingering question or something we learned from today. Who would like to start?
This is a heartbreaking thing. When people have severe, even moderate bile acid malabsorption, you just remember whenever that stool matches that picture, it's just so cheap to start them on a trial run of cholestyramine as long as it's in a safety profile for the patient.
Yeah, it's a great point. I'm very focused on infectious causes, and so this will be really helpful for which we'll talk about in other episodes, but it's not always an infectious cause or a post-infectious cause. It could be something completely different. So really good clinical pearl to just do a trial of cholestyramine.
Yeah, and I think my takeaway from today is really that you are not going to see this outside of the context of diarrhea. It always goes with diarrhea, even though the labs might be kind of wishy-washy on that. In constipation, that's probably not what you're going to be treating for folks. Cholestyramine does cause constipation too in some folks, right?
Which is probably one of the reasons why it's working.
Yeah.
Yeah.
And I'm just going to summarize one more time for myself mostly. So if we want to do any testing, most of us would probably want to look at a steatocrit on a functional lab test. The other testing is kind of complicated and challenging.
Right.
And we don't even really need lab testing if they fit the clinical history of urgency with greasy stools and they're having diarrhea, especially in the night. Just do a trial of cholestyramine if not contraindicated.
And it's by no means the only thing that causes diarrhea at night, like inflammatory bowel disease can, celiac can, parasites can, infectious causes can, but it is one of the things that causes stooling in the middle of the night.
Have it on your differential.
Yep.
Thanks, guys. Great episode.
Awesome. Good chat. Until next time.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the turd nerd word.